Good evening, everybody who may or may not be here tonight on Facebook Live. I would like to apologize for my lack of technical proficiency. And in the background, as there always is the folks I work with at Boston IVF who are so proficient in social media, et cetera. But my name is David Ryley, Dr. David Ryley. I'm a partner at Boston IVF. An infertility institution, if not one of the world's leading infertility institutions, that honors me to be a member of Boston IVF, but more importantly, honors me to help people of all stripes and persuasions, to assist them in building their families, to assist them in preserving their fertility, to guide and advise them on how they can best build those families, no matter what their makeup, no matter what their background. There's kind of a contract we make with people as we assist them in both infertility treatments as well as preserving fertility, that someday they will provide an environment in which that child will be loved, and therefore that child will thrive, and we can take part in that. I love taking part in that, and I'm humbled by that experience and by my profession and my ability to talk to you folks tonight. So thank you for joining me so late in the evening on a dark winter evening at 7 o'clock. I'm expecting to see some questions and to have the chat room opened up, and more than happy to entertain those questions. I can start off by letting folks know that what is it that I typically see when individuals or an individual comes into my office and they present with questions and concerns. What are some of those concerns? Very commonly, both men and women, more typically women or people who identify as such, will ask about, is there a special diet that might help them get pregnant? And the answer is essentially really no. And what I mean by that is you don't need a reproductive endocrinologist to tell you what your primary care physician or health professionals may have told you over your lifespan, which is eat a well-balanced diet, don't do bad things in excess, do things in moderation. That includes alcohol, that includes caffeine, and that includes all forms of those types of nutrients that might not be good for us when they're done in excess, but certainly in moderation, they're okay. I have a question. My first question of the evening is from a young woman who I believe is 39, and she mentions that she's been trying to get pregnant with her husband, and they've been trying for what seems to be 3 cycles, and she's wondering if it is time to see a doctor or perhaps not. Well, number one, the definition of infertility for women who are aged 35 or over are couples in which a female partner is trying to get pregnant, or an individual who identifies as female is trying to get pregnant, who are over the age of 35. If there are 6 cycles without success, meaning no successful conception that has led to a live birth, that's a definition of infertility. And it doesn't necessarily mean that you as an individual are not going to get pregnant. It means that as the window of opportunity is narrowing as you get older, you might want to see someone just to be able to identify some potential problems. If there's any obvious health problems apparent to you as an individual, you don't have to wait that full 6 months. If your cycles, for instance, are irregular, don't wait those 6 months. If you have a lot of pain with intercourse or pelvic pain or something abnormal, don't wait those 6 months. But other than that, there is a reasonable chance of a successful conception within that 6-month time frame. But after 6 months, it's worthwhile seeing a doctor to have that doctor do somewhat of an evaluation to help you understand what assistance may or may not be required. To what extent, another question, does stress from trying to get pregnant affect the time to conception journey? Great question. one that I get every day and one that I do such a bad job of answering. Okay, why is it difficult to answer? I live in a world of individuals who are trying to conceive. We're trying to think of methodologies to have fertility preservation for the future. And just talking about it elicits stress. And I don't have a control group without stress. And so it's literally statistically impossible for me to quantify what role stress is playing. We all know it's not a good one. Stress is never good. And so therefore, it probably has a negative impact on the journey to conceive. So the best thing I can offer individuals who are expressing stress as they try to get pregnant is to take advantage of what might be available to them. Here at Boston IVF, we have our Mind-Body Center. We have the ability to teach individuals about cognitive behavioral techniques that help de-stress, with some data that supports doing so and therefore decreasing the time to conception. Stress is not good, but again, it's hard to quantify. My thoughts on fertility supplements aren't good thoughts because, again, the data is not good. So this is a question that says, what are my thoughts on fertility supplements? There's a lot that's out there. And all I can say is, if you're eating a well-balanced diet and you're taking a multivitamin, you will have very likely enhanced fertility. But over-the-counter supplements that are not necessarily regulated by the FDA have not been shown to be very effective in enhancing fertility. The purpose of taking the prenatal vitamin, for instance, is to make sure that one's diet is being supplemented by folic acid. And why is that? Because a lack of folic acid will impact the health of a fetus. So it's all about protecting pregnancy, not necessarily fertility. So a lot of these supplements aren't regulated. I'm not a great fan of them because I can't, again, quantify their impact. But please be on a prenatal vitamin. Please have a well-balanced diet, one that is rich in grains, low saturated fats, vegetables, again, well-balanced. But over-the-counter supplements are hard to quantify in terms of their efficacy. I have another question from someone that says that this particular individual had 2 miscarriages in a row. And this individual is happy that she has conceived. I assume she identifies as a she, but should she see a fertility doctor? I think much of that question is predicated on your age. And certainly, if there's a 3rd miscarriage, absolutely see a fertility doctor. But within the context of those 2 miscarriages, if there's any other medical condition that exists that could be contributing to it, if there's any known autoimmune condition, if there's any known abnormality that you may suffer from that has been diagnosed by your gynecologist, so you already know there's something that's predisposing you towards it, yes, you should see that infertility doctor. If you're under the age of 35 and you're getting pregnant easily, I wouldn't panic. A miscarriage is, unfortunately, nature's relatively cruel way of preventing an abnormal pregnancy from continuing. And I think if you had a 3rd one, yes, it's time to be worried that these repetitive miscarriages are bad. But 2, for a woman or an individual identifies as such under the age of 35 is not something quite to panic about unless there's an obvious medical condition. I have another question. I think I'm missing the whole question because the size of the chat line, if I scroll up, again, my technical proficiencies aren't the best. Hello, I was wondering, with a history of recurrent pregnancy loss due to chromosomal abnormalities, if the polycystic ovarian syndrome can be a root cause due to immature eggs, any way to improve or treat this? The polycystic ovarian syndrome is not necessarily a cause of recurrent pregnancy loss, but I'm assuming that you've undergone in vitro fertilization and therefore have had embryos derived from eggs that have been retrieved. Their chromosomes have been looked at. And for those who may not know what chromosomes are, our cells are made up of chromosomes. It's where our DNA is packaged. As we get older, more of our cells, or more of the eggs we produce rather, have an abnormal number of chromosomes which predispose us to unsuccessful pregnancies, particularly miscarriage. So this question is probably due to the fact that this individual, because of this condition known as the polycystic ovarian syndrome, produced a lot of eggs, many of which were not mature and therefore could not be fertilized. And so the question is, can the treatments be more efficient because better eggs or more mature eggs will be more likely to yield to a live birth? And yes, there is ways to improve that. Number one, the way the cycle is timed, the way the eggs or the follicles containing those eggs are grown, taking medications that might be necessary to improve egg quality, things like insulin sensitizing agents, which often are needed for individuals with the polycystic ovarian syndrome, the most common being metformin. So there are ways to change diet, exercise, lifestyle, and the cycle of IVF to improve not really the quantity of eggs. It's not about quantity, it's about quality. So yes, that can be done. I'm going to go to the other side of my screen. When not ovulating, should I even try having sex for a baby? Temper my expectations. Well, 20 to 30% of women are infertile, defined as the inability to conceive a successful pregnancy over 6 to 12 months, depending on age, because of ovulatory dysfunction. And therefore, if ovulation is irregular, there's a higher rate of infertility. And interestingly, that particular diagnosis, again, affecting 20 to 30% of the patients that present, tends to be the easiest to treat. So I would not temper expectations. I would see somebody who can give you an ovulation induction agent, typically a pill, either Clomid, the more commonly known one, or Letrozole, otherwise known as Femara, for which you can induce ovulation in time intercourse and achieve a successful pregnancy. If your question is, if you're not ovulating, will you not get pregnant? I never tell anybody that they might not get pregnant, because ovulation can still occur when it's not expected. And many individuals who don't think they're ovulating might have a pregnancy if they're not trying to. But in the end, IVF is typically not required when you're not ovulating regularly in that particular type of condition. Again, affecting 20 to 30% of people who present with infertility, is the easiest to treat and often doesn't require IVF. I'm reading a question from people who obviously have been through therapies. For those individuals who have yet to undergo infertility treatments, I'll do my best to incorporate your understanding of these questions from people who have become experts. Do PGT-A normal embryos, those are embryos that have normally packaged DNA, meaning normal chromosomes, that have been thawed, biopsied, and refrozen, have lower success rates for pregnancies? Okay. Does PGT-A, again, checking chromosome status, help with success rates or just lower miscarriage rates? Spectacular question from someone who is well informed. Okay, so for those who are unaware of what PGT-A is, again, you're checking chromosomes of embryos. And when chromosomes are abnormal in number, the embryos tend not to implant as well. And if they do implant, they miscarry. Many embryos that are frozen have not been checked for chromosomes. So what has to be done, they need to be thawed. Then samples of cells that give rise to the placenta, that's known as a trophectoderm biopsy, are checked for chromosomes, and the embryos are refrozen, meaning it's preferable to do the chromosome testing before you freeze the embryos, as opposed to the question that's being posed here, whereas this patient is inquiring, well, my embryos weren't checked before they were frozen. If I thaw them to check them and then refreeze them to wait for the results, will that impact success with regard to getting a successful pregnancy? Well, there's no great randomized controlled trial that shows us whether or not doing that is going to impact overall success. There is some retrospective data, retrospective meaning looking at success rates from embryos that have been thawed, tested, and refrozen to suggest they do have lower success rates than when compared to embryos that were tested beforehand. Does PGT-A, which is this chromosome testing, help with success rates or just lower miscarriage rates? It depends on the age. Emerging data would suggest in the age group of individuals, particularly the person who's going to be carrying the pregnancy from age 35 to 40, maybe 38 to 42, who undergo PGT-A will be increasing their overall success and lowering miscarriage rates when they check chromosomes. There's less robust data to suggest that it's necessary and as helpful for women who are under the age of 35. And that emerging data has been increasingly become apparent. Here's a question. Hello, I'm 34 years old and have experienced 3 losses. This is the night of recurrent pregnancy losses over the last 2 years. I had 2 missed miscarriages and 1 ectopic pregnancy. All losses have been before 9 weeks or before my 9-week scan. My husband and I have had all the blood work and genetic testing and everything seems to be coming back normal. I am able to conceive very easily, but I just can't seem to make it past the first trimester. In cases like this, what's the most common reason for having such early losses? This, as expressed by the patient, is probably one of the most, if not the most exasperating types of issues that present. Okay, so what's the most common cause for miscarriages? Well, we've already talked about it, when there's an abnormal number of chromosomes. And as individuals get older and those individuals produce eggs, more of the eggs they produce have an abnormal number of chromosomes. And when those eggs fertilize, the embryos have an abnormal number of chromosomes. And when those embryos implant into the uterus, if they do implant, they miscarry, i.e. it's nature's way of preventing an abnormal pregnancy. This individual mentions that the losses occur around 9 weeks. And by far, the most common reason for losses at 9 weeks are due to those types of chromosome imbalances. I'm not quite sure from the question if embryos have been created in the setting of IVF that have been checked for chromosomes, but the other types of tests that would be done to determine whether other adjuncts would be needed, it sounds like it has been done, is certain autoimmune testing that might require the addition of medications and treatments to help sustain the pregnancy through the first trimester, particularly looking for autoimmune issues that when treated will improve placental blood flow. It's also extremely important, and it sounds like it's been done, that both partners who are attempting conception together have themselves a normal array of chromosomes, meaning their DNA is packaged in such a way that they don't have higher rates of abnormal sperm or abnormal eggs that create abnormal embryos. And it's really, really important to look at the architecture of the uterus. The uterus can be perfectly normal. That might be the case here, as is suggested. There could be congenital abnormalities of the uterus that require correction because those abnormalities are increasing the risk of miscarriage. There can be certain rates or extent of an inflammatory condition within the pelvis, known as endometriosis, that might be contributing to these recurrent losses. In the case of this unfortunate individual, and I do find losses to be brutal, and I'm very sorry for what you're going through, If all the testing appears to be normal and otherwise you haven't attempted genetic screening of embryos, I would recommend that in your age group at 9 weeks gestation, because very likely that is the cause. The ectopic pregnancy and its removal is somewhat unrelated to the miscarriage. Ectopic pregnancies are those pregnancies that are just that, they're ectopic, they're outside the uterus, typically in the tube, and removal of the tube will actually enhance future fertility and future treatment, because that abnormal tube was contributing to poor implantation of an embryo. I think another question, which is similar to a previous one, and it seems to be the same individual, we talked about it, was wondering if with the history of recurrent pregnancy loss due to chromosome abnormalities, if the polycystic ovarian syndrome, a syndrome where someone is not ovulating regularly, could be a root cause of immature eggs. Yes, but not necessarily a root cause of chromosome abnormalities or recurrent miscarriage. I have a question from someone who asked the question. They are over 40 and they're asking what is the best effective process to be able to get pregnant? Well, number one, it depends if you're infertile, and if one is able to successfully conceive within 6 months, they're not infertile. But if infertility has been diagnosed, and at age 40, about 50% of individuals identifying as women will be infertile. And the most effective way, not necessarily the absolute needed way, but by far, to answer your question, the most effective way to conceive at age 40 is IVF, without question. And that data actually comes from some really well done studies that were done in such a way that it involved the Harvard School of Public Health, Boston IVF, Brigham and Women's Hospital, that was able to show for couples who were 40 years of older, meaning the female partner or the person planning to carry the child, that anything less than IVF was really not enhancing fertility, mostly due to the fact that that window of opportunity to conceive is narrowing. So by far, it is IVF. Next question. My wife and myself identity is female. When you have an egg transfer, can you choose more sperm donor? I assume this is meant to say more than one sperm donor to create embryos, meaning if we freeze the retrieved eggs, could we choose different sperm donors to create embryos? We want to donate embryos potentially. The embryo donation part is a little difficult, but let me get to the first part of the question. Yes, you can use different sources of sperm. It's just key that that sperm has been adequately assessed. And how is sperm assessed? Well, it has to go through typically a sperm bank, and the donor, the sperm donor, typically has to go through FDA testing. That is done typically 6 months from the original time of the sperm or semen deposit until 6 months later, to make sure STD testing in particular has remained normal. And that is really important to screen that donor in such a way. Once that donor has been screened, that sperm can be released and utilized. And yes, you can use more than one sperm, and it is up to the lab to segregate the embryos from which source of sperm. And you could use those embryos to conceive, and you could choose from one sperm source or from another sperm source. So yes, you can do that. In terms of donating embryos, if the intent of creating embryos is to donate them, that's a whole different story, because you wouldn't be coming to a fertility center for the purpose of getting pregnant. You're creating embryos for someone else. So if you have surplus embryos that have been created within the context of trying to get pregnant, you could donate those embryos, but you go through an awful lot to do so. FDA testing has to be done, and this FDA testing is special, basically STD tests that have to be done at specialized labs. Legal contracts would have to be drawn up, and you can't create embryos for the purpose of donation. They have to be created for the purpose of getting pregnant, and in rare cases, surplus embryos could be used for future donation, but that is not typically done, and there's a lot of legal roadblocks involved with that. What are my thoughts on apps for ovulation? Are they better than a urine ovulation kit? Actually, yeah, I do. I think the apps are better. I think urine ovulation kits are okay, but the apps seem to be somewhat more precise. Although I say that recognizing, you'll hear me say this a lot, there's no statistically rigorous randomized controlled trial comparing the two. You're going to see some study that suggests cervical mucus is going to be just as reliable when you look at the cervical mucus. The experience of my patients seems to be that the things that work the best in identifying ovulation are the ones that are the least stressful. And if you are technically proficient and you like apps, and that's least stressful, then that's what you should do. The less stress, the better. If you're better peeing on the ovulation predictor kit, then that's better for you, because I find that so much of this timing with ovulation predictor kits and machinery or technology can induce a level of stress that's counterproductive. So whatever's the less stressful will be the more successful. And I do tend to sense that the apps seem to work better. I'm looking at the question and answers and I wasn't scrolling down. So let me go to that side. If you've had 2 unsuccessful IVF cycles with another fertility clinic, how important is a second opinion with Boston IVF? That's impossible for me to answer. But what I can say is this is the type of field that second opinions are important. Whether that patient or that couple or that individual is going from Boston IVF to another center, or if they're coming to Boston IVF, I would never begin to even claim to sell myself at the expense of another really good clinic. But the importance of that second opinion, whatever direction the patient's going in, whether it's towards Boston IVF or not, is another set of eyes. And sometimes that set of eyes will give you the level of reassurance that, okay, my healthcare staff, my reproductive endocrinology and his or her staff, it's being endorsed by someone else, and that makes me feel better, and that feels good. So do I think second opinions are important? I encourage them. I think patients do really well with them. And for the purpose of knowing that another set of eyes has looked at it, you'll probably find pretty helpful. So whether you come to Boston IVF for a second opinion or another well-renowned clinic, and the beauty of living in Boston, we're replete with them, I think it's a good idea. What are the chances, difficulty in getting pregnant or difficulties in getting pregnant due to the male, and what studies should be? This is a great question, and the answer tends to be surprising to a lot of people. The number one cause of infertility, the number one single cause, is due to the male. So whenever you undergo an infertility evaluation, and there's no really known medical illnesses of either partner, if 2 partners involved, that are causing this, what do we tend to find out? Well, in essence, 20% of the time to 30% of the time is due to the fact that one partner is not ovulating regularly. That's pretty obvious when a patient comes in because the menstrual cycles are irregular, so that's easy to figure out. 5 to 10% of the time, it's due to abnormalities within the uterus that are either predisposing that person to recurrent pregnancy loss, failed implantation, or infertility, poor obstetric outcomes, whatever it might be. 25% of the time, it's going to be due to abnormalities, often blockage of the fallopian tubes. And what's the most common cause of that? Well, typically previous STD exposure, which can often go undiagnosed. Or it could be due to inflammatory conditions within the pelvis, such as those that are from previous surgery, inflammatory conditions such as endometriosis, which is associated with painful periods, that can cause scarring, which blocks tubes. But the most common diagnosis are the ones I've listed. 40 to 50% of the time is due to the male. And 25% of the time, everything comes back normal. And so the answer is it's unexplained infertility, but the most common signal diagnosis is the male. And the question here was, and what sides could these be? Well, the number one bioassay for assessing the male, the number one bioassay is taking a health history. You know, what is his overall health status? What medications is he on? What kinds of surgeries has he had done? And most importantly, looking at his semen. And that semen, the set of parameters that are looked at, the quantity of the semen volume of the ejaculate, the motility of the sperm, how it's moving, the shape of the sperm, and the concentration of the sperm, all of which can be impacted by a number of issues that would require evaluation from a urologist who specializes in fertility. And whether or not those semen parameters can be fixed, whether it's by treating an overlying medical condition or just fixing the semen problem, because that's the sole issue, that will dictate, depending on how well it's fixed, on whether IVF is required, which is typically the case, or maybe something like insemination can be done. But overall, the number one cause of infertility, especially in couples who present younger, is due to the male. And the best bioassay beyond the medical history is looking at the semen parameters. If a chemical pregnancy just occurred through an insemination, should a cycle be skipped to allow your body to heal? If it was just biochemical, so for those who might not be educated about this, insemination is where basically you're enhancing exposure of eggs to sperm, where you're concentrating sperm, you're flushing it through the cervix. In the natural act of intercourse, 100 to 300 sperm make it into the tubes to fertilize an egg. With insemination, it's 1 to 3 million. So that's what insemination is. A chemical pregnancy is a very, very early miscarriage. If this insemination was done with a pill to enhance ovulation, such as Clomid or Letrozole, or was just done naturally, you really don't need that month's rest. If this insemination was done in conjunction with hormones that stimulate the ovaries with a lot of growing eggs, and that's not a typical treatment algorithm that's done these days, then yes, you would need that month's rest. But for biochemical pregnancy, no, I don't see the data that would require that rest unless that special typical type of injectable medications were employed. Okay, I'm going to go back to the chat. I don't understand the question, so you might want to send it back. It said, I'm operated, can I get pregnant again with doing IVF? I'm not quite sure I understand the question, so if you want to send it back, let me know. What is the best treatment if we have polycystic ovaries and have problems to conceive and being overweight? One of the main epidemics in this country and in the Western world impacting our ability to ovulate regularly is a condition known as the polycystic ovarian syndrome. And it's very basic level. When a woman or an individual who's planning to carry a pregnancy ovulates, they produce a hormone called FSH. You're going to hear a lot about that when you're talking about infertility. That's the follicle stimulating hormone. That's the hormone that's getting the egg to grow. And then when that egg reaches a certain size, which is typically around day 12 of an otherwise intended 28-day menstrual cycle, the estrogen coming from that egg tells the pituitary gland it's time to release that egg. And the pituitary gland, in response to that estrogen, will release another hormone called LH, something you also hear about with infertility. And the LH will result in the release of the egg. So in essence, in a 28-day, the classic 28-day menstrual cycle, the FSH grows the egg, and then the LH releases it. At its most fundamental level, the polycystic ovarian syndrome occurs when that LH hormone is dominant throughout the cycle, and it's preventing that FSH from growing the egg. Some women, that LH to FSH imbalance just is, and we can't explain why. More than likely, it's coming from neurotransmitters in the brain that we can't identify. But often, it's due to the epidemic we have in this country related to being overweight. Because when one is overweight, they often produce more insulin, and that insulin in turn stimulates the ovaries and that whole system I just described to help maintain that LH to FSH imbalance. Therefore, there are lifestyle changes that can improve that entire paradigm. Losing weight, being on a low carbohydrate diet, exercising well, medications called insulin sensitizing agents that lower those insulin levels and improve that FSH to LH imbalance. So there are things that can help. In fact, at Boston IVF, we work with a nutritionist who pretty much wrote the book on the dietary needs of patients with PCOS and how those types of changes can help alleviate the dysfunction. But so often, when you do that exercise, when you eat better, when you exercise in a way that promotes this healthy lifestyle, and you can take a pill that helps induce ovulation, you end up not needing expensive, or I shouldn't say expensive necessarily, but intense treatments such as IVF. So in essence, good exercise, good nutrition, insulin sensitizing agents will help with the polycystic ovarian syndrome. I had 2 ectopic pregnancies and 1 miscarriage. My fallopian tube has endometriosis. Can I do IVF? Not only can you do IVF, you should do IVF. If you have a fallopian tube that has been so impacted by endometriosis, it's likely that that endometriosis is classified as severe. And at that level of classification, there's probably many factors that endometriosis is doing to contribute to your infertility, whether it's hormonal factors, whether it's structural rearrangements of the fallopian tubes predisposing you towards ectopic pregnancies, whether large collections of that endometriosis is causing an inflammatory condition preventing good implantation. Studies have shown that IVF is necessary in those situations to overcome those issues to which you are predisposed from the endometriosis. So I would recommend IVF in that situation. What is the likelihood of conceiving if sperm has low motility, parentheses 13%, close parentheses, if under 30? It's a really tough question to answer. You could still conceive. However, in the setting of infertility, so conception hasn't occurred, and you're under 30, and you've gone 12 months without a successful conception, the man or the individual with that semen analysis with persistently low motility should be evaluated, because in the setting of infertility, it's probably playing a big role. The most common reason for low motility, when other parameters are good, there's something called a varicocele. A varicocele is a dilated blood vessel, like varicose vein, on the scrotum, which can lower the efficiency and motility of sperm and therefore the fertility of the couple that's trying to get pregnant. And repair of that varicocele can restore the semen parameters to normal. So yeah, you could get pregnant. Hard for me to tease out the data what the chances might be. But if you've gone 6 to 12 months without conception, then that individual should be evaluated. And one of the concerns would be a structural issue such as a varicocele, which can be easily fixed, and normal fertility and normal semen parameters restored. Hi, I have done 3 egg retrievals in the last year. I am 38 years old with less than 2 to 3 eggs retrieved and only a total of 2 embryos. Both were tested and we only had 1 normal, which we transferred but ended in a chemical pregnancy. Is there anything to help improve egg quality? This is an incredibly common story. I don't want you to feel alone at all. It's not your fault. You can't predict it. You can't prevent it. Very common story. It sounds like to me at age 38, you're doing IVF and you're getting relatively low egg yields. You probably have what we call a diminished ovarian reserve, which means that your response is lower than one might expect. And it's hard to test embryos, meaning check the DNA, meaning check the chromosomes, because when you have a low egg yield, and therefore a low embryo yield, they might not even make it to the point where that they can be tested. There is some data from mice. I know that sounds odd, but you'd be surprised how similar the reproductive cycle of the mouse is to the human, that suggests when older mice take CoQ10, which is an over-the-counter supplement, and earlier I didn't say I endorse them, but I do like CoQ10, that might improve the response to treatment because CoQ10 serves as a source of energy for eggs, helping them to divide better and perhaps make better quality. This could be one of those areas in which you might do better if you have committed yourself to IVF, not genetically testing your embryos, but transferring them earlier in their development to see if you can improve the chance of conception in that fashion. And sometimes it means that despite multiple efforts, it could require an egg donor. It might not. That's not meant to scare you. But there's many ways to do that. You don't always have to test embryos. You can transfer more than one on day 3 of their development, increasing the odds that a conception that is successful might occur higher than what nature is giving to you. But yes, supplements like CoQ10 are useful. Going back to the question and answers, I'm not quite sure I know how to answer this question other than to say, one of the reasons I am proud to be at Boston IVF is, in a way, how I started this conversation. We're all about helping individuals build their families and assist them in providing an environment in which they will love their children and those children will thrive irrespective of the parenting of that child, whether it's a woman, whether it's a woman and a man, whether it's somebody who's transgendered, whether it's somebody who might not identify as binary, whether it's a gay man, whether it's 2 gay men, it doesn't matter. So this question, the reason that was my prelude, was that this individual is with her gay friend, James, and he is concerned that he will have to invest so much to have children someday. Well, number one, there's many ways to have kids. One way is to adopt. And number two, it is a big investment for gay men as couples or as individuals to have children. It involves the use of an egg donor, obviously, typically anonymous, and it would involve the use of a gestational carrier. So yes, James, it's difficult. It's hard. But I have so many gay couples who have inspired me for doing what I do, because they, 40% of the pregnancies in this country are unintended, and I don't live in that world. I live in the world of the incredibly intended. And some of these men and these individuals are so invested, both emotionally and financially, in building their family, that despite that incredible investment, it has been well worth it for them. That's the best thing I can say. They are very happy individuals. Here we have a question. Does Boston IVF review lab work, parentheses, blood work, close parentheses, as you progress through an IVF cycle with the patient? What feedback can you provide a patient to help them understand how their body is responding to IVF medications? I think the best feedback you can give a patient who's going through IVF is at the beginning of the cycle, so they understand what's going on. So typically, what I like to do with an individual who's starting IVF is I show them a diagram. And I mention to them that every month that an individual attempts to ovulate, her pituitary gland produces a hormone called FSH, follicle stimulating hormone. Its purpose is to stimulate the group of eggs that are ready each month to ovulate. And as a result, each month out of the group that's ready, one egg gets released, all the others die off. And with IVF, we're supplementing the FSH, and by so doing, we're rescuing those other eggs from dying off. So it's important for that patient to recognize we're not stealing future eggs, we're not causing future infertility, we're saving the eggs from that month that are going to be used to create embryos. And as part of that initial discussion, I tell them that estrogen levels, most importantly, are going to be monitored in a way that reflect a steady growth of follicles that will synchronize and develop the eggs as a good cohort that will be released. And I tell them that if it's too high, oftentimes that means we have to freeze the embryos derived from those eggs, because when it's too high, it can cause a syndrome or be associated with a syndrome called the ovarian hyperstimulation syndrome, where if you get pregnant, you get rather ill. So it's best to retrieve the eggs and fertilize them. Or if things are too low, it suggests you're not going to do well and you have to cancel the cycle. So if I have that discussion with that individual up front, they have a better understanding of how that cycle is going to proceed. And my nursing team, every day that a patient, like all my partners, every day a patient comes in, whether it's a weekend, whether it's a holiday, I'm looking at the data. I am looking at how that estrogen, for instance, is rising, what it means, what it reflects, how it correlates with the ultrasound, and therefore what is meant to do next. So therefore, by talking to my nurse, who tells them what to do next, they are talking to me. If there are problems that are outliers, that are not consistent with that initial discussion, that is not a job for my nurse to tell them, because they need to hear more. That's a job for me to interject and say, okay, you're doing great, you're over-responding, but I need to change this to a cycle where we're going to freeze all your embryos, because I don't want to get you pregnant this month because you're going to get rather ill. So that's pretty much how we and I individually run the practice. Will letrozole or Clomid induce an immature egg? No, that's not how they're designed. They're designed to induce ovulation, and by inducing ovulation, you're getting a follicle to reach a certain size and release a dominant mature egg. Yes, there might be another egg that's immature, but the focus is on the 1 or 2 mature eggs, and that's how those medications are designed. What is the likelihood of conceiving if sperm has low motility? We already answered that question. I think I might have silent endometriosis, parentheses, heavy bleeding, close parentheses. How can I advocate for myself. Anytime you go to a gynecologist or a primary care physician, if your bleeding is heavy, and for instance, you're saturating more than a pad per hour, and it lasts for 7 days, something to that extreme, advocating for yourself is the recognition that that's not normal. And if it's not normal, could it be endometriosis? It might be. It might not be endometriosis. It could be something else called adenomyosis. Adenomyosis is endometriosis of the uterine wall that's associated with heavy bleeding. It could be due to structural abnormalities in the uterus, either the development of fibroids, which are benign tumors in the uterine cavity, or polyps, which are kind of like fleshy growths in the uterine cavity. So it might not be silent endometriosis, but it's not normal to have that level of heavy bleeding. And yes, it should be investigated because its treatment is only going to enhance future fertility, and lack of treatment is not going to help future fertility. Is it possible just to do fertility injections without IVF? Yes. The old paradigm of treatment for patients, for instance, with unexplained infertility, meaning all the tests were normal, was to start simple with medication like Clomid and intrauterine insemination. And then if that didn't work, it was followed by injectable medications like you do with IVF and insemination. And if that didn't work, it went to IVF. And that was based on population-based data and, believe it or not, insurance dictates. Insurance was trying to get you to do everything before you got to IVF. It's really not that done very commonly anymore, for the simple reason studies pretty much out of this institution in conjunction with the Harvard School of Public Health showed that that middle step was of taking the injections with insemination was only increasing high-risk pregnancies. You were having triplets, you were having twins, you were having quads. So you weren't increasing overall success, you were increasing risk. And the time to conception was longer. And it was better to move to IVF. And the insurance companies, in all their practicality, recognized that they were actually saving money by going right to IVF because of the higher rate of success and the lower rate of high-risk pregnancies. So the answer to your question is yes, you can do it, but it's somewhat fallen out of favor over the last decade or so. I'm going back to the chat. Bear with me, you guys. This is something that thanks me, and I'm too embarrassed to say it, but you're welcome, Elizabeth. Like I said at the beginning of this talk, every time I see patients and talk to patients, I am humbled. So thank you for the thank you. You recently had a total gastrectomy. Will I be able to get pregnant with IVF in the future once I heal? The answer is yes, but not without a consult with a maternal fetal medicine specialist. So yeah, we can get you pregnant. We just need a uterus, and we just need the appropriate embryos, and we need to make sure all the pelvic anatomy is good. But obviously, you know, as a patient who just had a gastrectomy, and I hope it went well, by the way, has nutritional requirements, excess vitamin requirements, et cetera, that can impact the health of a growing fetus. And so any reproductive endocrinologist would say, yeah, we can get you pregnant. We can assist with that endeavor, but we would have you see a maternal fetal medicine specialist to guide us on how to provide you with the right way to proceed once you are pregnant. Hi, Dr. Ryley. My question is this. I will be 42 this March and have 2 miscarriages over the last 4 years. My husband is 58 years old and we did all the tests and everything back normal. My husband and I are still trying. I am taking prenatal vitamins and my husband takes folic acid. Is it helping us? It's not hurting. At age 42, it's hard to get pregnant. It's hard. The incidence of infertility, meaning the inability to conceive a successful pregnancy, at least 6 months of trying, the incidence in that age group is at least 50%, if not higher. And remember, when we're talking about infertility, we're also talking about recurrent pregnancy loss. By far, the best way to approach that treatment is IVF. The data would show that with IVF, over 6 cycles, and that's a hard road, that success rates can range from anything as low as 23 up to 42 to 50%. That's the range. So if you listen to the way I said that, 50% is the max over 6 cycles. But that is far higher, that's exponentially higher than what nature is conferring to you. So I endorse the idea of IVF. I do recommend doing more than 1 cycle to try to hang in there, recognizing as that window of opportunity is narrowing, you're getting such a higher success rate than nature is conferring to you, because nature at this point is probably conferring to you less than a 5% chance per month. Certainly, taking prenatal vitamins and folic acid definitely can't hurt. For me to quantify how it's helping is impossible to do, but well-balanced diets, supplements like prenatal vitamins are always good. My partner had to go through prostatectomy, I'm sorry to hear that, and had sperm banked at the hospital. Will that be used for IVF treatment or have to draw new sperms? What is the upper age limit for a woman for IVF? I think the question here is, this is male factor infertility. The prostatectomy has led to a lack of any more sperm, if not other forms of infertility, such as ejaculatory dysfunction or erectile dysfunction, and the need to store sperm. Very likely, there's a limited supply of sperm, and as such, IVF should be utilized, because with IVF, you can manipulate the amount of sperm you use as opposed to using a lot, which typically would be the case with insemination. Typically, the upper age limit for a woman for IVF is up to the 44th birthday, because there's really no data to support any reasonable chance of success over the 44th birthday utilizing IVF, due to the fact that nearly 100% of the eggs, despite being stimulated, are abnormal and tend not to fertilize, or if they do fertilize, create abnormal embryos which don't implant, or if they do implant, result in miscarriage. What is the process? This is a good one. What is the process for a second pregnancy if you have frozen embryos? A hell of a lot easier than the first process. The beauty of coming back for frozen embryos is that you don't have to go through IVF. The IVF is done. That's the beauty of IVF. IVF is doing 2 things. It's assisting you in getting pregnant, and it's preserving your future fertility. There's essentially 2 ways to do a frozen embryo transfer, otherwise known as a thaw cycle. My favorite is in women who ovulate regularly. They ovulate regularly, they have regular menstrual cycles, and what you typically do is you thaw that embryo timed with ovulation. So think of it this way. When a woman gets pregnant naturally, the sperm gets into the fallopian tube, it fertilizes the egg. And then the embryo that results grows. And by the time that embryo lands in the uterus, it's 7 days after that woman essentially had the LH surge that made her ovulate. Well, that's how you can do it with a frozen embryo. You monitor her ovulation, you give her the surge, and 7 days later, you thaw and transfer the embryo into the uterus. It works great for women who ovulate regularly, and 10 days later, you get a pregnancy test. So basically, I just told you, you're taking 1 trigger shot and getting a pregnancy test. A hell of a lot simpler than what IVF was. Many women, for medical reasons, such as those women who don't ovulate regularly, that's not going to work, because for certain medical reasons, they're just not going to ovulate or respond to ovulation-inducing drugs. So therefore, you have to simulate ovulation. You have to give them hormones. So when a woman prepares her uterus naturally for pregnancy, she produces the 2 female hormones: estrogen, which builds up the uterine lining and creates a bed for the pregnancy, and progesterone that helps maintain that bed. So we simulate that. And typically, you take estrogen, most oftenly done orally for about 2.5 weeks. And once the lining's thick enough, you have your pregnancy bed. And it's at that point you start taking progesterone. Typically, the progesterone is given as a shot, or you can take shots every 3 days with nightly vaginal progesterone. But the bottom line is, on the 5th day of that progesterone, you thaw and transfer the embryo, and you get your pregnancy test 10 days later. If you're pregnant, because your body's not producing any of this estrogen and progesterone that's created this pregnancy bed, you have to take the estrogen and progesterone until 10 weeks of the pregnancy, until the placenta takes over and maintains the pregnancy. So it's a hell of a lot easier than IVF. It's really great when you can time it with ovulation, but some women have to take the estrogen and progesterone hormones. A former patient just said thank you in ways that, again, humble me, and you're more than welcome. Another patient said that, and another patient said that. Wow, this is the David Ryley thank you hour. I'm embarrassed. What is the cost of IVF? Is that the question? The cost of IVF is pretty much predicated on, number one, is insurance covering it? And if insurance is not covering it, the cost of the medication is the most expensive part. These medications are really sophisticated and labor intensive to make. My guess is the average cost of an IVF cycle, if these embryos are being transferred and some are being frozen, probably runs anywhere, depending on the dose of medication, from $10,000 to $15,000. If embryos are being created for genetic testing and then being frozen and followed by a thaw cycle, and insurance isn't covering that, you're paying for the IVF cycle. That's probably ranging in the $15,000, maybe as high as $20,000 range, and then the thaw cycle about $4,000. Bear in mind, doctors are idiots when it comes to talking about the financial costs of medicine, and you have financial advisors that help tell patients about these kinds of things. Luckily, we live in an area and a state in which infertility appropriately is recognized as a disease. And since it is recognized as a disease, it's typically covered by insurance. More thank yous. You're welcome. And I love the names I'm seeing. It brings back incredible memories. And one of the hard parts about IVF, and I realize this isn't about me, but you see patients through their journey, and some of those journeys are hard and long, some not so hard, not so long. And then they're pregnant and you don't get to see them because they're seeing your nurse practitioner or your physician's assistant, because they no longer need you because they're pregnant, and you never get to say goodbye. And then come holiday season, you get a nice card. But it's great to see old names like that and wonderful memories. Going back to the question and answer board. I have PCOS. Would fertility injections and letrozole together help me without having to do IVF? The vast majority of the time, you don't need to do the letrozole injections together. You could just get away with letrozole in combination with some of the other issues we talked about before, such as exercise, weight management, and diet. Most patients with the polycystic ovarian syndrome do not need IVF. This is a great question. I have diabetes and was diagnosed with PCOS. Is it possible that I can still get pregnant? Absolutely. You might need some assistance, again, using letrozole, the pill that works really well to induce ovulation and to overcome the PCOS. And with regard to the health of your upcoming pregnancy, making sure your impaired glucose tolerance is in good control. And the best measurement for that is the hemoglobin A1C. And for the uninitiated, hemoglobin A1C just refers to what percent the red blood cells have sugar in them. And the percent that have sugar reflects how well that individual has been metabolizing their blood sugar. And when the hemoglobin A1C is above 6%, we're somewhat concerned because, most importantly, that's going to impact the pregnancy, increase the rate of miscarriage, and increase the risk of certain birth defects, such as the most common like spina bifida and heart defects. So when impaired glucose tolerance and or diabetes has been diagnosed, yes, you can definitely get pregnant, but you want that hemoglobin A1C to be under good control. Typically, you don't need IVF. You get pregnant using letrozole to induce ovulation. I do believe someone just said I would not suggest a parallel prenatal pack. I'm not well versed in parallel prenatal packs. Just a regular OTC prenatal will do. Yes. If there's at least 400 micrograms of folic acid, sometimes up to 800 micrograms of folic acid for patients with certain medical conditions, particularly obesity or having babies with certain birth defects, that's all you really need to supplement a well-balanced diet. Doctor, would you consider canceling a cycle? I assume you're talking about IVF, after insurance being approved for having a BMI of 41 with a high AMH. Not outright cancel, but it depends on the response to treatment. When you have a high AMH, oftentimes that is the most sensitive reflection of how one might respond and how one might hyperstimulate and therefore need to freeze their embryos, if you're calling that cancellation. Freeze their embryos before a cycle is done to thaw them, because if they got pregnant during that cycle, they would get really sick from the hyperstimulation. So in other words, individuals with a high AMH often over-respond and need to freeze their embryos if you call that cancel. But no, I wouldn't outright cancel somebody because of a BMI of 41 and a high AMH. I would not. I would certainly recognize that this individual should see a maternal fetal medicine specialist to help guide them on how to manage their pregnancy and help optimize the health of that upcoming pregnancy with regard to being overweight, for instance. Where is my office located? I think Emily just answered that question. In the land of Zoom, we're all located anywhere. It doesn't really matter, because luckily here in Massachusetts, patients have access to insurance that covers Zoom consults. You can see any one of us anywhere. I, in particular, in downtown Boston, at 1 Liberty Square, in a beautiful office that I love. But you don't have to live near this office to use it. We are pretty high tech. We can Zoom with all our patients and do our monitoring anywhere that is the most convenient for them. Here's a great question that's probably better answered by a urologist who specializes in the male, but I'll give it a shot. Doctor, my husband is 35 and I am 34. We are trying natural conception and had our first cycle of unsuccessful insemination at Boston IVF. His tests found good sperm motility and count, but 100% abnormal morphology. Morphology for the uninitiated is just the shape of the sperm. Is that a major factor in not getting pregnant? Studies suggest no correlation so far, which we have read by NIH. Is there a cure for this? I'm not the guy to answer whether there's a cure. If this was just based on one semen analysis, it's time for another semen analysis, because the vast majority of the time, when the concentration of the sperm is good, when the shape is good, that day of poor morphology is just an off day. Semen parameters vary all the time. And there's many men, I am sure, that have gotten pregnant with 0% morphology. However, that being said, if repeat semen parameters, no matter what the concentration of the sperm, persistently showed low morphology, that could definitively be impacting the ability of that sperm to fertilize the egg and perhaps reflect certain genetic disorders that need to be investigated. So the answer to the question is, yeah, you can get pregnant with 0% morphology, but if you're having trouble getting pregnant and it's not working, repeat semen parameters should be assessed and a male fertility specialist might recommend IVF to overcome the poor fertilization related to that low morphology. And I think this is coming from the same person. Follow-up, we had 2 semen analyses, both showed 100% abnormal morphology. I would see a male fertility specialist. I would. I think it's to have that persistence of low morphology and the impact it might be playing on fertilization. I do feel it's warranted to see a male fertility specialist. I had a tubal ligation. They removed part of my tubes. Is it okay to have IVF done? I have had 3 C-sections. It's absolutely okay to have IVF done. IVF, and I don't know how old you are, but unequivocally, almost the vast majority of the time, patients who've had their tubes tied, tubal restoration is difficult, not nearly as successful as IVF. One of the dilemmas you run into that situation is that once you've had your tubes tied, meaning voluntary sterilization, as it's so termed in the healthcare profession, insurance probably would not cover the IVF. My wife is 46 and I am 42. We got married in 2006. We have never experienced a pregnancy. The wife's tubes are blocked and she does not ovulate, which suggests to me she might be perimenopausal. So do you think IVF will be okay? IVF will be okay, but it will be with the use of a donor. At age 46, there is no sense and no good data to support the use of her own eggs. The success rate is essentially 0. So you already have a 0% success rate if the tubes are blocked. You already have a 0% success rate if you're not ovulating, but the age of 46 confers to IVF a 0% success rate. So using an egg donor would be the way to go. The good news is egg donation is wonderful. My patients have taught me much more than I could ever teach them. And for women or individuals who identify themselves as someone who wants to carry a child, donor egg has a success rate over 80%, and an egg donor is no different than a sperm donor. All she's doing is donating DNA. Life is conferred to the embryo derived from that egg donor by your uterus, by your placenta, by your blood coursing through that fetus's and therefore that child's veins, by your nourishing that child. That's the biologic connection that confers motherhood. And my patients who choose donor egg, 100% of them, 100% are so happy they did. Now that's a biased group because not everybody chooses it, but of those who do, they all say the same thing. Number one, they wish they had done it earlier. And number two, the lack of a biologic connection unequivocally is replaced. The lack of a genetic connection is unequivocally replaced by the biologic connection conferred by that pregnancy. But at age 46, for all the reasons I mentioned, including the age of 46, donor egg is the only way to go. I really want to do family balancing. I believe this question probably reflects the fact that this individual, no matter how their previous children have been conceived, has children of one gender, and they want to select embryos of a certain gender to optimize conceiving a child of that gender. Is it offered? Yes, but it's offered with the provision that you have to recognize that you may have surplus embryos that are perfectly normal and they're of the undesired gender, and you have to be willing to use those embryos. But yes, you can choose embryos for the purpose of sex selection. I think, oh my God, we've gone an hour and a half. I hope I haven't been too boring. And I try to do my best to keep it relatively light and not sound too much like a doctor. And my nurses constantly complain that all I do is confuse the patients because I do talk too much like a doctor. But again, it's been a pleasure to participate in this. I could often talk about this forever. It's a wonderful experience to be part of, and I love helping families of all stripes assist them in conceiving their children. These questions have been great. They've been difficult. But they've been great and appropriate. And none of those questions that have been asked, none of you are alone. Those are common situations, and you're not alone in these endeavors. Thank you very much. I think it's time to close off, and I hope everybody has a wonderful Thursday evening, upcoming weekend. Thanks.